So yeah, hello to those of you who I don't know. I'm Sam. I'm one of the ST5 which is currently at Reading, and talking about cerclage. This may have been something that you've already seen. It might be something that's completely new to you, but we're going to go through what they are, why they're done, when they're done, and how they're done. So there's various different ways. And also at the end, a little bit about how this is relevant to you. So we're going to focus mostly on things that are in guidelines and what the recommendations are, which is great for people who are thinking about doing exams in the next year or two. But just day to day, there's also some stuff which is quite relevant to you, which you will see in, for example, maternity assessment units. So this is relevant at the moment because there is a new guideline which came out last month on cervical cerclage. This is an update of a very old previous guideline, and it's quite extensive and worth a look. It draws quite heavily on the pre-existing guideline from a few years ago, which was the NICE preterm labour guideline, and it builds on that a little bit. What becomes difficult, and you'll find this as you do start looking at Part 2 exams in particular, is that guidelines start contradicting themselves. So there's a little bit that is inconsistent between these two guidelines, but for the most part, it's quite good. And they also both draw on, somewhere else, they draw on the Saving Babies' Lives, there it is, guideline as well, which we'll touch on. So the reason that this is important is cerclage is mostly relevant for preventing preterm birth. Preterm birth broadly described as birth before 37 completed weeks, for the sake of this talk and the guidelines, is the biggest cause of babies being unwell or dying in the UK. Further to this number, which is about 7% of babies, the second trimester losses, which are, for the most part, combined with preterm birth as a composite adverse outcome, which is what cerclage is aiming to reduce. And of the, I think, 5 pillars of Saving Babies' Lives, this is the second version, preventing preterm birth is one of the key focuses. So, can you shout out, please, some risk factors for preterm birth? And I'm talking specifically about the spontaneous ones, obviously not ones that we are causing.
Infection.
Infection, yeah, particularly intrauterine, but also others.
Uterine anomalies.
Mm-hmm.
Previous fully dilated section.
Previous fully dilated section, yep.
Smoker.
Say that again.
Smoker.
I can't hear that.
Sorry, if the mum's a smoker.
Smoker, yes, partly because it's I suppose association with other diseases, and also as a kind of makes tissue quality worse.
Multiple gestation.
Multiple births.
Yeah, multiple births, multiple gestation. Yeah, excellent. And these are broadly summarized, if you think of underlying mechanisms, of what is commonly called cervical insufficiency. It was slightly tactlessly used to be called incompetence, which I think we're moving away from slightly. And it's a bit of a broad, slightly subjective term still. It's often treated as quite a binary thing. A cervix is competent or incompetent, or sufficient or insufficient. But really what it probably is a spectrum of things. And that is formed by a combination of different mechanisms, making it more likely that a cervix is going to dilate, associated with a predisposition to a cervix effacing, that is becoming short, starting to dilate, and losing the mucus plug. All of these things, therefore, exposing the inside of the womb that should be protected to the outside world, makes it more likely that you're going to give birth. So you talked a little bit about this. I'll just skip over this really because you mentioned it in preterm birth. There's various things which specifically predispose to cervical insufficiency, which I think I did. Yeah. So quite a lot of the time we don't know. So people have preterm births or go into labour early for no previously known reason. But they're also more common in people who have had less procedures, had various bits of or the entirety of your cervix removed for whatever reason, usually cancer or pre-cancer, fully dilated sections, which is down to cervical trauma, uterine variants, that's kind of Müllerian anomalies. And to an extent, it's been proposed that connective tissue disorders are going to predispose to this as well. So these are people with not enough or not well functioning collagen. So there are various things that are done or can be done to prevent this, and we're going to focus obviously on cerclage today. But quite a lot of people who have identifiable risk factors, or even if this has happened before, choose to do nothing. So you can watch and wait, see what happens, knowing that there is an increased risk, but you need to watch. And this can be combined with some form of monitoring or surveillance. Progesterone, so that's usually either a vaginal pessary or a rectal suppository, it's increasingly used throughout much of gynecology and obstetrics nowadays. You'll see increasing use of it for recurrent miscarriage, bleeding in early pregnancy, that kind of thing, although it's quite controversial still. And it is used quite commonly for people with a predisposition towards preterm birth, with or without cervical cerclage. So I take a look at that if you want to look at that separately. I'm not going to touch too much on it today. So there are different kinds of stitches. Has anyone had an experience of seeing, removing, having previous teaching about cervical cerclage? Anyone seen it at all?
I saw one done actually about a week or two ago, and a lady who'd previously had a cone biopsy.
Mm-hmm.
And I remember my consultant specifically mentioned that actually it had been really technically difficult because her cervix was almost flush with the vaginal
Yep.
wall. So yeah, but that was my first time seeing one done properly.
And where was that?
That was in Wexham.
Wexham. Okay, interesting. Thank you. Yes, so they're a thing that they don't come up very often. And we'll talk about a little bit about why later. But there are various different kinds. And it can all be a bit confusing as to which one to do and when and what they're called and what they actually entails. So they can be broadly broken down into ones that are done through the vagina and ones that are done through the abdomen. So transvaginal cerclage and transabdominal cerclage. Various ways of putting these in, all with different names and different suture types. And there isn't really very good evidence that one of these works better than the other, except in certain situations. So the general aim when you're holding, when you're putting a stitch to hold a cervix together, is you want to try and get it in as high as you can, because that basically gets closer and closer, or even at the level of the internal os, which is what you want to keep closed. So sometimes this isn't possible. It sounds like what you just described with quite a flush cervix. You've not really got an awful lot of cervix to work with, so you're just going to put it where you can. These will tend to be quite low on the cervix and entered transvaginally. These are quite often these are your McDonald sutures, and that can either be a Merslin tape, which looks like a long shoestring, or it can be a often monofilament or something like proline. That is a much thinner, and you can put these in either lower down the cervix or high up after having reflected the bladder. That's your high transvaginal stitch with a bladder reflection, and an example of that is the Cervical stitch. There are sometimes combinations of these, so it's quite common, particularly in Oxford, that I've seen that you put in two. So you put in one below the other, and we'll come to why later. It's very important to document that how many stitches you have put in. And yep, so they're your main kinds. Other ones is transabdominal stitches. They can either be put in before pregnancy or in early pregnancy, and they can be a combination of open or laparoscopic procedures. The one which is mentioned in the guideline at the bottom there is your occlusion stitch, which is basically stitching the external os closed as a way of removing tension. I've never seen this, and I don't think it's very commonly done, but it's in the guideline anyway. Any questions about those ones?
Sam, when would you do a transabdominal stitch?
Good question. So that you can either do it, you're generally doing a as I will come to, you're usually doing a transabdominal because a previous transvaginal stitch hasn't worked, or there is no cervix there to stitch externally. So they're people who have had multiple cervical procedures, or they've had a failed stitch. And so you can either do that prior to a future pregnancy, before they start planning to conceive, or when they're in early pregnancy in that first few weeks.
Great, that makes sense. Thanks.
It doesn't
So
affect.
this might be a really stupid question.
Don?
How does it work if you're doing it before pregnancy? As in for
You mean
conceiving?
fertility? Yeah, it doesn't
Yeah,
affect.
it might be a really obvious question, but in my head it doesn't work.
No, it is, and they mentioned this in the new guideline as well, where they didn't used to, is that it doesn't affect it. So basically, you can conceive normally.
Thanks.
Yeah. Okay. So there are three different kinds, and we're going to go through the different kinds. So not kinds so much as in suture type and where they're inserted, but in why they're done, when they're done, and how they're done. And they can all be broken down into history indicated, ultrasound indicated, and emergency. And we'll take these in turn. So starting with your history indicated sutures. These are people who are often referred to antenatal clinic hopefully in these first few weeks of pregnancy, ideally in the first trimester, as people who have a high risk of subsequently having a preterm birth. And you want to get them seen by a specialist, ideally in a specialist preterm birth designated clinic, which it is recommended every unit should ideally have. And there are certain criteria that have to be met. So for reasons that we'll come to later, it should be a singleton pregnancy. To get a history indicated suture, according to the new guideline, you should have had at least 3 preterm births. So that's any birth before 37 weeks that was spontaneous. And there is not good evidence, or there's not evidence that having fewer than 3 preterm births is any good and does not warrant cervical cerclage. What is a little unclear still is the importance of other risk factors, like having ruptured your membranes early, but having had cervical procedures and things in the past. It's a little uncertain, and there it opens up a slight grey area about people who have had fewer than 3 preterm births plus have other risk factors, and then it becomes a little bit subjective. But what has been shown in several studies, we're talking big randomized controlled trials here. No, that's not true. Big observational studies. is if you put in a history indicated stitch at between 11 and 14 weeks usually, you reduce the instance of preterm birth quite substantially, but you don't change perinatal death on the whole, not statistically significant. Can anyone think of a reason why this might be? Why do you think you would see a reduction in preterm birth, which is significant, but not necessarily a change in perinatal death?
Is there an infection association?
Infection association. Maybe.
I suppose it implies it's not just the fact of the premature birth that causes the morbidity, it's something else that goes with preterm birth. Because if it was purely preterm birth, then it would solve the problem, but there must be another factor that is related to preterm birth that is also causing morbidity.
Yeah, I suppose, and those things might be associated with your propensity towards preterm birth as well. Yeah, I see what you mean. Yep.
The trigger factor is still there, but you're just preventing the consequences of that by putting in the stitch. So it holds the pregnancy for longer, but the trigger factor that actually would have led to a natural early delivery would still be there and affecting the baby.
Yes, a cause and effect thing, I suppose. Yes, absolutely. What I'm specifically thinking of is to do with the definition of preterm birth. Historically, we've used a slightly earlier cutoff to be where we're interested of less than about 34 weeks. And babies that are born, if you use that definition of preterm, or really quite preterm, severe preterm, have a higher instance of perinatal death. But babies that are still technically preterm, but about 36 weeks, don't often die. So if we're successfully getting pregnancies further along and closer, but not quite meeting 37 weeks a lot of the time, they're very unlikely to die. But it means that we're successfully getting past this danger zone of about 28, 32, 34 weeks. We won't see an awful lot of history indicated sutures, but you see relatively more ultrasound indicated ones. So these are for people who you're surveilling to watch out whether they get a short cervix or not. And we'll talk about how that's done. So again, they should be singleton babies. You tend to focus on people who have had a preterm birth or a mid-trimester loss. So this is generally between 16 and 34 weeks. And also have a short cervix, which is defined as a cervix of 25 millimeters long on a transvaginal scan or less. They need both of these parts to warrant having an ultrasound indicated suture. And they're quite clear that if you happen to pick up an incidental finding of a short cervix and they don't have a history of previous preterm birth, you don't change the outcomes by doing a cerclage. But when these criteria are met, and you do put in a cerclage compared to people who don't, you reduce the incidence of birth before 24 weeks quite substantially. You do decrease the incidence of perinatal death because you're preventing a lot of these births at very early gestations. But as I said before, you don't really see changes in perinatal death at later gestations, as in closer towards 37 weeks, and it's uncertain as to whether these really materially affect preterm birth at later preterm. These are generally put in between 16 and 24 weeks, reasons that I'll explain, because you need to be checking them for their ultrasounds. So there are things that make you more high risk or less high risk for it all going a bit wrong and needing to have a cerclage put in during pregnancy. You've spoken about most of these already. So they're people who have had it before, people who have ruptured their membranes at early preterm gestations, people who have previously needed cerclage for whatever reason, uterine variants, we're talking about unicornuate uteruses, uteri. Intrauterine adhesions is one that I've never come across. I need to look into this a little bit more because I don't see an awful lot of a clear mechanism of why that would change that much. So I'm going to have a look at that. And trachelectomy, so that's your cervical amputation. These people are really quite high risk of having preterm birth in the future. And from 16 weeks, they should ideally be having a transvaginal scan every 2 to 4 weeks, up until the point of 24 weeks. And if at any point the cervix becomes short, that's the point at which you would put an ultrasound indicated cerclage in. There are people who have a slightly lower risk, but they're still higher than the population average. And these are people who have had a fully dilated cesarean section in the past, and people who have had some kind of cervical trauma. Generally, these are people who have had more than one LETS procedure in the past, or a cone biopsy, which aren't really done very commonly these days. And the third interesting one there is people who have had what they describe as a LETS procedure that's more than 1 centimetre deep. Now, I have never seen a LETS report that actually gave the depth of the tissue that had been taken, and so I don't see this as being something which we can use very well in clinical practice. I don't know if anyone's had a different experience.
Sam, sorry, I will say,
yeah,
they do put it on histology reports, but you've got to go into the report and they will tell you what size of the tissue is, and usually it's the last measurement which will tell you the depth. So when I'm triaging these patients, if they've been done in Reading, so I will go back and have a look. Or sometimes, you know, at the time of the biopsy or the LETS, they will tell patients, you know, I'm worried about your future pregnancy. And so lots of these women will hang on to that, and they will tell the midwife at booking. And we always err on the side of caution, and we would do offer a transvaginal scan in preterm birth clinic. So you can find it.
Absolutely, and that's something which I think is really good about Reading, because I've not seen that anywhere else.
Point taken. Yeah.
So that's really, really good. Thank you for that. And like you say, they do get offered a scan. And this doesn't necessarily need to be serial surveillance. This can be a one-off, done around about the time of the anomaly scan, between 18 and 22 weeks. But if they're having it done at 20 weeks, you may as well do it then. Good. And then coming on to your emergency ones. So, can anyone tell me what I mean by emergency cerclage?
Is this
When
a
somebody
person?
presents.
Oh, wait,
Go ahead.
In the
Go ahead, check out.
strategic review last year, was there a
So when someone presents,
not
um,
this specific thing, but
and I get like there needs to be a reason that you've looked at their cervix that you can see that they're opening, but then they need to be not contracting and not bleeding. So I guess maybe they've presented initially with some bleeding or initially with some tightenings, but then everything settles, but you do still see that they're open.
Yes. Yeah, you're right. So something has happened that meant that you've looked and picked up that they need a cerclage. And that's generally because you can see membranes. Yep, cervix is opening. Yes, you're right. And what do you think are the... So presumably the benefit is clear, is that you want to close the cervix to prevent that from dilating anymore. What do you think is the challenge or the significant risk that can happen by putting an emergency cerclage in?
You could rupture the membrane.
Yeah, rupture the membranes.
Infection.
Infection. Yes, exactly. And what do you mean by infection?
You can get choreo.
I suppose the point is that if it's already happened, there might already be an infection, and by putting a foreign body in, you're introducing a really big locus for that to grow and worsen and make the outcome even worse than it would have been otherwise.
Yes, exactly.
Yeah, they definitely have to be like sure that there's no signs of choreo before you put the stitch in.
Yeah, exactly. That's what I was going for. So it's when you say infection, you're absolutely right. I'm trying to discern whether you mean cause or effect. So whether you think I'm going to cause an infection by putting the cerclage in, or is there an infection there which is predisposing the cervix to dilate and the membranes to bulge, and therefore if you put a stitch in and close that cervix around the infected bag of membranes, it's going to all go quite badly. So these are things we have to think about. So again, criteria for cerclage: single baby, you're seeing the membranes because the cervix is open. And this can be varying degrees of open. It can be a centimetre or less open with the bag membranes coming through it, or it can be 9 centimetres and the membranes are in the vagina. If you successfully get a cerclage in, it does delay birth by an average of about a month, which is fantastic if you put it in at ideally post 20 weeks, because then you're kind of heading towards a viability, and although that does bring in with it its own problems, but if this happens at 16 weeks and you're there then delaying it by about a month, you're still in quite a dangerous place of about 20 weeks. When they're successful, they do reduce the instance of birth before 34 weeks. But there is a little bit of inconsistency between the studies reporting whether they actually improve outcomes for babies being born alive or well. And again, I think this probably has something to do with when you're doing them. Are you delaying a birth to a post-viability gestation, or are you delaying it and they're still pre-viable, therefore you wouldn't really see much of a change. And these are generally done at, there's a typo there, this should be less than 28 weeks. Sorry about that. So you do them up to 27 weeks and 6 days. So, like you said, there are some reasons why you would not do an emergency cerclage. That's if they're in active labour, they're having regular painful contractions, you can't put it in. If they've got chorioamnionitis, now this can be quite hard to discern. Anyone who's kind of reviewed someone that you thought I might have chorio will have come up against this problem of, is there a blood test that's very good for working it out? Not really. There are good and bad ways of doing things, but it's not very reliable at best. One thing which is done in certain areas but not others, and doesn't form any kind of national guidance, is at the moment is amniocentesis. So one way of doing this is to do an amnio, take a sample of that fluid, test it for bugs, see if it grows anything, a bit like you would with a lumbar puncture, and that gives you a fairly good idea of whether there's an infection there. The new guideline says there's no convincing evidence that that conveys any benefit and does come with a small amount of even theoretical risk. But it is a thing which you'll probably see. Other reasons that you should not do it is because they're bleeding actively, if they've ruptured the membranes, and things which might seem straightforward, but you may not have thought about obviously before, is you're doing this for fetal reasons only. So if the baby is already compromised, already dead, or has a lethal anomaly, there is no real benefit to be doing this, and it's all risk and no benefit in those situations. Any questions on that?
Yeah, I have a question. With regards to the amniocentesis, first, is it done transabdominally or is it done transvaginally through the prolapsing membranes? And the other thing is, what do you do time-wise? Do you wait for a full culture to identify an organism, or do you just look it under the microscope for white cells, or what do you do with that sample after it's taken?
Yeah, good question. Transabdominal to obtain it, and there is an algorithm that is, so the way that it's done in Oxford, or at least was until last year, and again, this is not UK-based guidance, but American, there's an algorithm that takes into account microscopy and the glucose concentration.
Okay.
Because, like you say, waiting for the full culture will take quite a while, by which time it's too late. And so that's a retrospective finding usually.
Thanks.
Okay. Right. What are we doing for time? Fine. So you've spoken about this already. As with most things, most surgical procedures, there's a risk of bleeding. And that's because you're putting a stitch into the cervix. There can be cervical trauma as a result of the procedure, or also if the stitch successfully goes in and then they go into labour, that stitch that's in place can tear through the cervix and needs to be removed promptly. You've spoken about the risk of rupturing the membranes. This is particularly important and higher risk when the cervix is more dilated, generally more than about 4 centimetres, and less of a problem when it's done for a history indicated reasons where the cervix is hopefully still long and closed. Bladder damage becomes relevant when you're doing bladder reflections. These are things like your Cervical sutures, and shouldn't be a problem when you're doing lower McDonald ones. And similarly, I suppose, for transabdominal cerclages, you want to get that quite low down towards the internal os, and you're going to involve a bit of bladder reflection there as well. They're usually done under spinal anaesthetic. But what they're quite keen to emphasize in this new guideline is that if a cerclage goes in and is uncomplicated, that stitch being there isn't a risk factor for infection, such as chorio, doesn't increase the likelihood that your membranes rupture further to the background risk, and doesn't increase your risk of preterm birth by the virtue of it being there. So, has anyone seen, heard, or got any thoughts on cerclage with multiple pregnancy? What are your thoughts?
I've never really considered it. I mean, there must be a reason because I've never seen one. But my first thought is, well, it is in itself a risk factor for preterm birth. So if you've got pre-existing risk factors, you'd think it would be an indication rather than a contraindication.
Yeah, I agree. This has been highly debated and is still disputed. Like you say, multiple pregnancy increases your risk of preterm birth. There was a fairly seminal paper a good few years ago now that said that counterintuitively putting cerclage in the multiple pregnancy increased the risk of adverse neonatal outcomes. There wasn't a clear mechanism behind this. And there have been lots of studies on it in recent years, but it's still, even in the new updated guidance, that it doesn't recommend doing cerclage for multiple pregnancies in the absence of other risk factors.
And Sam, is there a role for cervical length monitoring?
Yes, it is recommended. So most places that that look after twins will recommend having at least a cervical scan at some point, usually in the mid-trimester. Which then begs the question a little bit of why. Because if you're not recommended to put a cerclage in, why are you checking for short cervix? But I suppose there is that caveat there of it recommends not doing a cerclage of multiple pregnancy in the absence of other risk factors, and that might count as one of the risk factors. It all becomes a little bit grey. There was a really big case series of over 100 last year, which showed no difference in outcomes in terms of early preterm birth and perinatal mortality and morbidity between twins and singletons. But that wasn't taken into account, and this guideline was probably a little bit too late. So it's highly contested, and I would say still quite commonly done. There's nothing to say that maternal obesity affects the outcomes. We talked about transabdominal cerclage and why that might be done at different times. And you might have seen arabin pessaries. So these are harder pessaries which are aiming to reduce cervix tension on the cervix. Although there is not an awful lot of evidence for them at the moment, but a very large study has just been done, and they're analysing the results of that at the moment, and we're waiting for that to come out. So that's the kind of the information bit. I was going to go through some little questions that I'd thought of to see if they might be relevant to you. Does anyone want to ask anything about what we've done so far before I carry on? Anything unclear?
Just regarding the point about them not being a risk factor for infection, so does that really mean that like the consent form for one of these won't include infection as a risk? It just seems really counterintuitive for any procedure that you're not going to do that, no matter what somebody has managed to show in a paper and developed. You know what I mean? Yeah,
I suppose there's still theoretical risk. If you're pushing, you tend to, I don't know if you've ever seen an emergency cerclage, but you basically put either a catheter or a swab on a stick and push the membranes back up into the uterus and stitch the uterus, the cervix closed. I see that as a bit of a theoretical risk of introducing infection. But yeah, at least guideline wise, it's quoted as not a risk factor for choreo.
Seems very brave. Okay, thanks.
Okay. Nope. Right. So these, I could have called this things I've done wrong. And you may well have come across some of these already. And let's see what you make of it. Someone comes into maternity assessment at somewhere between 16 and, I don't know, sometime after 16 weeks with a cerclage in. What are your thoughts on whether you do or don't do a speculum, or do you change what you do?
I think you can do a speculum, you shouldn't do a bimanual.
Okay.
Potentially really important to do a speculum, because if something is happening, you need to really know and be ready to remove it.
Yeah. So these are high risk people, I agree. They've got, even with a stitch in, which is aimed to keep the cervix closed, they are at higher risk than the average people for dilatation, for membranes still bulging through, for preterm birth, for infection, etc. Well, apparently not infection. And yes, speculum, as always, being gentle as you can, is appropriate. If you feel more comfortable going with somebody who has done more of these than you and say, you know, this is a high risk one, I want to make sure that I get exactly what I'm going for, then ask someone to go with you. Take a registrar or somebody else and get a bit of support. What do you think about fibronectin and partashores?
They're not valid. I think it will be dramatically increased with the presence of a cerclage, whatever else is happening. I think.
Anyone seen this? Anyone done this?
No, I don't know about FFN, but about Partashore or Omnishore, I don't. If it's there to detect amniotic fluid, the presence of a cerclage with intact membranes, I don't see how that would be affected.
So I think we're probably thinking more. Yeah, I know what you mean. We're thinking more about the partashore, so the threat of preterm labour rather than that have they ruptured their membranes. But yes, the way the guideline answer is they might be of limited value, but a negative one might be reassuring. So in my simplistic brain, I think of these kind of tests as a way of saying, do I think this person is objectively at increased risk of going into preterm labour? If they have a positive result, that would probably say, yeah, that would help my clinical decision making, and I think I'm going to take this seriously. I think they've got an a priori high risk of something being relevant, and you should already be taking this seriously. So the result might not be super useful. However, the guideline says that if you do it and it's negative, you might be somewhat more reassured. I would still have quite a low threshold for taking it seriously. What do you do if someone with a cerclage ruptures their membranes?
So in my experience, what you do is you call Lawrence and P or Christos and ask them, and they'll tell you what to do.
So escalate. Yeah. Anyone seen this? Has anyone seen it happen in practice? No. Yeah. So this is when that contentious argument of cervical cerclage being in place, not causing infection, becomes untrue for sure, because when you've got ruptured membranes and there is a foreign body there, it increases your risk of there being infection. The second thing to say is that once, if about roughly half people who break their waters go into labour within the next day or two, there's a high chance they're going to go into preterm labour. And we've talked about cervical trauma that happens as a result of that. So this isn't something which I would be expecting you to do without discussing. In fact, don't do that without discussing. But generally, the answer will be it needs to come out, with the caveat that if you want to try and buy a little bit of time to do things like get your steroids in and do an intrauterine transfer, then it can be delayed for up to about 2 days.
I have a question.
Yeah, go for it.
Is this even in the absence of contractions?
Yes.
So yeah, so if they shrom, then the stitch, it has to come out.
Generally, I've seen situations where it hasn't, but the textbook answer, the one for your exam, is it generally needs to come out after your usual senior escalation and personalized management plan, that kind of thing.
Okay, thank you.
Same goes for people who are contracting. So we kind of talked about this. I would have a very low threshold for taking these things seriously. If there's any doubt, even though there's a risk of maybe admitting people based on a softer indication, and maybe you're just being a little bit overcautious, personally, I would have a low threshold for admitting someone and getting a good senior review. There might come a time when these things come up on elective lists, and someone might offer to for you to do it, and that's happened. Now, it's always great to get new experience of these things. The general rule with these, as according to the Saving Babies' Lives bundle, is that these things aren't done very often. They're a bit like amniocentesis and the miscarriage association in early pregnancy. The outcomes are better for people who do these more often. So people that are doing them all the time do them generally better, and they recommend them being done at a supra-regional level. That means that you will see fewer of them done in district general hospitals, and more commonly they will be referred upstream to be done by people who are doing this all the time. And so I would be great, get new experience, definitely want to see them, but get a senior person to do them and watch many, be supervised in a good situation. And these are things which should be done by people of appropriate experience. Be cautious. And coming to the end now, removal. Has anyone removed a cerclage? No.
Did once with my.
I have at the time of C-section after the delivery of the baby.
Yeah. Good. Time of section. Yeah. And what kind of one was that? Was that a Merslin one? Was that a Proline one? How did it go?
I don't remember the details. Sorry.
Okay.
It was like a purse string shaped one. There was a tape. Yeah, the consultant held the speculum up so that I could visualize it, and I just cut it, and then with the forceps, I just pulled it and just confirmed with the notes to say that there was only one placed.
Great, excellent. Sounds ideal. Yeah, this is a thing which you can quite reasonably be expected to do. Sometimes they'll be in a labour ward, you put them in lithotomy, take it out. Sometimes, particularly if they were ones with a bladder reflection, you'll have to go to theatre and have some anaesthetic to remove that. But yeah, removal is a much easier process than putting them in. But there are some very important things to remember. And again, this is things I've done wrong. There it is. Generally, they'll be removed between 36 and 37 weeks, or at the time of caesarean section, if that saves visits. It should be clearly documented from the insertion of how many stitches are put in, because you do not want to accidentally leave one in. And you want to get the whole thing out. So this is my Microsoft Paint example of cerclages. This is what they look like. This is them going around the cervix as a purse string. So you can see on the left, this is what they look like when they're intact. It's got the purse string, the knot, and the two strands. What you want to do for this middle one is cut one of the arms and then pull it by the knot, pull the entire thing out. And then when you take it out, you want to see that all three of those parts of it are in place. What you do if you don't do it quite like that is you cut the knot off. And what that means is that a load of suture material is left inside the cervix, which in itself might not cause any problems. It might be a theoretical infection risk. It might be found later, and it does get quite taken quite seriously. It can be uncomfortable, and it's the kind of thing which I had never been told, and so I'm telling you. Apart from that, having had a cerclage to try and prevent preterm birth isn't in itself usually a isolated indication for a caesarean section or induction of labour. And specific things to do with transabdominal cerclage are when you do a caesarean section, the transabdominal cerclage stays in situ. So you just make the incision in the lower segment as you usually would, and you leave the stitch down there at the bottom, usually leaving it in, because they may want to go and have a subsequent pregnancy. And in the event of an intrauterine fetal death, you need to consider, unlike most situations, whether you do a hysterotomy, a caesarean section, for people with a transabdominal cerclage, although there is always the theoretical risk of doing a posterior colpotomy to cut the cerclage if they are adamant that they want to have a vaginal birth. That's it. Whiz through cerclage. Does anyone want to ask anything?
So in general, Sam, if you've got a transabdominal cerclage, you would be suggesting cesarean section because obviously you can't take the cerclage out and have a vaginal delivery.
Yep, transabdominal cerclage generally means cesarean section.
And so, you know, if they then end up not becoming pregnant again, or they have further pregnancies or whatever, does it eventually need to be removed, or can they just stay in?
It can stay in indefinitely.
So I know part of the general advice given to women with sutures of all kinds is to avoid intercourse in pregnancy because of the in inverted commas infection risk. I'm just wondering, well, firstly in general, but secondly, in light of what we were talking about earlier, is there any actual evidence of that, or is that just part of a kind of a cautious approach? Are we still recommending that, or?
So the 2020. Yeah, go on. The 2022 guideline says you don't need to recommend that they abstain from sexual intercourse.
Interesting, thank you.
Yeah. Good question.
Can I just ask, from an SHO point of view, after the cerclage is inserted, does the guideline mention timing and duration of progesterone, antibiotic creams, indomethacin if it's an emergency? Yes or no, and if yes, for how long?
Yeah, good question. So this is where it gets a little bit woolly, probably due to the quality of the evidence that has been done. For tocolysis, so these are things like your theory is that you're doing something to a cervix and uterus that might make it more irritable. So giving tocolysis at the same time or for a few days afterwards, like indomethacin, might calm it down. There isn't compelling evidence for that, so they can't recommend that you do it, but it is commonly done. I think they say that there isn't also good evidence for concurrent use of progesterone and a cerclage, although again, it is commonly done, and I can't see why it would be particularly harmful. So in your kind of your risk-benefit balance, there's not an awful lot of risk to it. And so I think it will be commonly done as well. Antibiotic creams, I'm not sure about.
Thank you.
Okay.
I think to follow on from that, it's also very confusing because everyone seems to do something different,
Yes.
and doses and, you know, how long for. So I think unfortunately there won't be any standard guidance, so it will just be whatever that consultant prefers to do. I know at Reading in the preterm birth clinic, if someone opts to have progesterone pessaries as opposed to having the cervical cerclage, it's usually recommended they have 200 milligrams progesterone twice a day. But like I say, it does vary.
Yeah, and generally up to somewhere between about 34 and 36 weeks.
6 weeks, yeah.
Yeah.
Thanks, Sam. That's super useful.
No problem. Like I said,